Assalamu alaikum warahmatullahi wabarakatuh. Welcome back to the channel of Stand Medical Notes. So, in the previous video, we have discussed till the differential diagnosis of SSTI, meaning skin and soft tissue infections. Let us move forwards and begin with the name of Almighty. So, what would be the diagnostic approach for uncomplicated, remember this word, uncomplicated skin and soft tissue infections? So, this is heavily reliant on astute clinical judgment, thorough physical examination, and careful history taking. And in that, microbiological stewardship is very important, meaning unnecessary use of antibiotics should not be done, and if necessary, antibiotics should be given. So that should be kept in mind. So remember, in mild cases of in mild uncomplicated cellulitis, in mild uncomplicated cellulitis, investigations are not required actually. Whereas in cases of moderate to severe infection, so as defined by the IDSA classification, which was discussed in the previous video, one requires this investigations. Okay, so in mild uncomplicated cellulitis, you don't require any investigation except some high case scenarios. Okay, high case scenarios nothing but moderate to severe infection or special scenarios like zoonosis or exposure to salt water, like that. Okay, that's clear. Okay, now what investigations you require? The investigations which you require is, one is culture, the pus culture. Okay, if the pus culture or blood culture, it can be pus or blood. So if it is not non-purulent, you can take blood culture. If it is purulent, you can do pus culture. The second one is laboratory evaluation. Okay, and the third one is imaging. One is culture, second is laboratory evaluation, third is imaging. Okay, so in high risk clinical scenarios, nothing but moderate to severe infection, like if there is systemic toxicity or hemodynamic instability or suspected bacteremia, meaning sepsis, or if the host is significantly immunocompromised, like severe neutropenia, active malignancy, post splenectomy, advanced HIV, or special exposure is there. What is that special exposure? Animal or human bite wounds. Okay, animal or human bite wounds, aquatic immersion injuries, fresh or saltwater exposure, or recurrent or refractory infections failing the empiric therapy, then you require this culture. Okay, so culture is required, remember just one thing, in moderate and severe infection and in special exposures and if failed therapy. Okay, so what are that? So when to take cultures, I have explained now, and how to take culture, and what things should not be done while taking culture. Okay, for pus culture, there should be deep tissue aspiration. Remember the word aspiration, not taking a swab. Deep tissue aspiration or deep surgical punch biopsy of the skin, or direct aspiration of pus from the abscess core via incision and drainage. So these are the methods. Either you aspirate the pus from the deep tissue. So deep tissue aspiration. So this is not pus, actually it is aspiration of deep tissue, and this is aspiration of pus if you have abscess, and this is deep surgical punch biopsy. So these are the three methods of culture. What not to do? Don't swab the superficial pus. So this is a pitfall. So do not perform the fallacy of the superficial swab. So superficial wound or pus or open ulcer should not be swabbed. Culturing intact skin, superficial purulent exudate or base of chronic open ulcers is universally condemned by infectious disease guidelines. Superficial swabs reflect environmental colonization, normal commensal skin flora, pseudomonas on wet wound, not true invading pathogens. So if you take a superficial culture, it will be normal commensal. Okay, and what will happen? What will the result? Antimicrobial therapy erroneously tailored to these colonizers guarantees therapeutic failure and promotes multi-drug resistant organisms. So that is about all about culture, how to culture. Okay, then what are the laboratory investigations? So laboratory investigations include CBC with differential, basic metabolic panel for a like urea creatinine electrolytes, serum lactate, LFTs, and coagulation profiles. Unexplained marked creatinine kinase elevations can suggest myositis or deep clostridial myonecrosis. So elevation of CK elevation is a marker of necrotizing infection. Remember, blood marker of necrotizing infection. Okay, or some clostridial myonecrosis, purulent pyomyositis. So that these are the basic investigations. Then imaging. So imaging involves, one is POCUS, point of care ultrasound, and second one is CT. So where POCUS is done in subcutaneous fluid collection or edematous cobblestone fat appear, you will have these two findings. Either you can have subcutaneous fluid collection or you can have edematous cobblestone fat, meaning panniculitis. Okay, fat, inflammation of the fat, that is. So modern standard of care for differentiating cellulitis from acute abscess. So by using POCUS, meaning ultrasonography, you can differentiate whether pus purulent site is present in cellulitis or not. And these facilities are available bedside. IND decreasing treatment failure rate. Now, when you require advanced imaging like CT MRI, so to delineate true anatomical depth, identify gas tracking along facial planes, diagnosing contagious osteomyelitis, mainly osteomyelitis, and to know the depth of infection and to see whether any gas is present or not. There you require advanced means. So these are the three important investigations, three type of investigations we perform mainly in moderate to severe infections. Okay. Now, one absolute warning: if the patient has suspected necrotizing fasciitis, so it is a fundamental clinical diagnosis. What is that? Pain out of proportion will be there, systemic toxicity will be there, bulle will be there, cyanosis, some ecchymosis can be there on the limb. So the step is immediate surgical exploration. So what should you do? Surgery is ultimate diagnostic modality, visualizing necrotic non-bleeding fascia and definitive life-saving therapeutic intervention. Advanced imaging must never delay the surgery. So you should give empiric broad spectrum antibiotics if you suspect this, and you should refer the patient to surgery department. That's about diagnostic approach. Okay. So in mild infection, if it is purulent, you can perform culture. But if it is non-purulent, then nothing is required, no investigation is required. But for moderate and severe infection, you require all basically blood investigations and cultures, and in some cases ultrasonography and CT scan. Now, what should be our management strategy? What should be our management strategy? So remember, it is a management strategy constitute triad. What is the triad? Effective management, effective evidence-based management tests on a triad. One is mechanical source control. Here, mechanical source control. Second is targeted antimicrobial therapy. Third is host factor optimization. Okay, these three are the cornerstone of management triad. Okay, so let us look on the first one, mechanical source control. So primacy of incision and drainage. So IND, cornerstone for all purulent SSTIs like abscess, large furuncles and carbuncles. So before that, you should give adequate local anesthesia, often regional blocks, and generous incision should be given. Probe aggressively. What that means? Blunt dissection should be done. Curved hemostat should be used to rupture internal loculation. There will be pockets, pus pockets. So to rupture that, you should use curved hemostat and fibrous septations. Ensure complete evaluation of purulent payload. Okay. And remember the 5-day rule. 5-day rule in uncomplicated non-purulent cellulitis, meaning mild cases of mild non-purulent cellulitis case. So 5-day rule. What is that 5-day rule? 5-day course of highly effective provided patient 5-day course of antibiotics is highly effective provided patient demonstrates positive clinical trajectory by day 5. Resolution. What is that positive trajectory? Resolution of systemic signs, erythema, stabilization, or so. If the patient does not have any purulence and it is uncomplicated cellulitis, then giving 5 days of antibiotics, and at the 5th day patient is having signs of regression, that is erythema is stopped, it is not progressing, and systemic signs has resolved, erythema stabilization or regression and systemic resolved, then 5 days therapy is enough. So this is for mild. So just giving antibiotics is enough for uncomplicated non-purulent antibiotics for 5 days, provided it should have a positive clinical trajectory by day 5. Now coming to the second one. Okay, second one, Antimicrobial stewardship, duration and evolution of therapy. So rapid de-escalation is favored now. What that means, for moderate to severe infection, for moderate to severe, so mild infection we have seen here, this one. So 5-day rule is enough for moderate, mild infection. For moderate to severe infection, it is not this. So for moderate to severe infection, initiate IV antibiotics. So, and if the patient responds, then transition to highly bioavailable oral agents like cephalexin, first generation cephalosporin, cotrimoxazole, doxycycline. Exact movement what is the exact movement? Hemodynamic stability achieved and lesion stops rapid progression. So this is the time where hemodynamic stability is achieved and progression of the skin infection is halted. So this is the time you should transit from IV to highly bioavailable oral therapies like cephalexin, cotrimoxazole, and doxycycline. Now, other point. Intravenous therapy offers no inherent advantage over bioavailable oral drugs once patient can absorb enteral medications. So, what is the evolution now? What is the evolution? So, clindamycin was very much used initially now, but its use for MRSA is decreased now for Staphylococcus aureus. Why? Because of rising resistance. Approximately Staph aureus of more than 25-30% in some regions, resistance is there, and there is high rate of adverse GI events like severe Clostridium difficile. Clindamycin is downgraded to an alternative now. What is that alternative? The alternative for clindamycin is doxycycline is there. Okay, for to cover the MRSA, or cotrimoxazole. So both cotrimoxazole and doxycycline can cover MRSA. So number one is doxycycline. Doxycycline is replaced clindamycin now for MRSA, mainly for MRSA. Now it is reserved now. It is not that you should. It is reserved where the susceptible is, where the isolate is susceptible, meaning the staph aureus is susceptible. Then you can use clindamycin. Where you suspect penicillin allergy or antitoxin properties because of its antitoxin properties, what it does is, so we have read toxic shock syndrome, okay, and de-exfoliative toxin, staphylococcal scarlet skin syndrome and toxic shock syndrome, where what happens, the culprit there is the bacteria produce the toxins in them and they release into the circulatory system. So to halt that production of exotoxin, this clindamycin has the role. So for that purpose we can use this. Okay, now what is evolved now? These long acting lipoglycopeptides. So these will break the cell wall actually. Vancin, you can remember vancins. So dalbavancin and oritavancin. So because they have a very good half-life, so 1 to 2 weeks, if you give one infusion, they will act for 1 to 2 weeks. So give single IV infusion in ED or absorb. They have ultra long half-lives. This bypasses admission and oral therapy lines and immediate discharge is possible. Intravenous immunoglobulin may directly bind circulating exotoxins, and this is an ongoing debate. So, but clindamycin can be used for this antitoxin properties. So some other things to remember is systemic antibiotics cannot penetrate the avascular acidic core of a mature abscess. Without pus evacuation, medical therapy will fail. So this point to remember. So adjuvant anti-MRSA oral antibiotics based on guidelines 2024, 2020 or 2024 updates add oral antibiotics like cotrimoxazole or doxycycline after incision drainage if the abscess was more than 0.5 to 2 cm in size. It improves the cure rate by more than 80% and drastically reduces the recurrence and new research. This is actually for adjuvant antibiotics is for mild cases of mild purulent SSTI. So there is a debate whether to use for mild cases of abscess antibiotics or not. So but for mild cases of mild purulent SSTI, you can use these antibiotics as adjuvant for 5 days, 5-day rule. Okay, similar to mild uncomplicated mild cellulitis. Okay, non-purulent cellulitis, uncomplicated mild and non-purulent cellulitis, similar. So as a supplement therapy you can use. Okay, so better to use in mild cases of this one. But in moderate to severe cases, you need to start IV, and when you see response like the system now the patient becomes stable, he is able to take orally, okay, and the progression of the lesion is not there, it is halted, then you can switch on to the highly bioavailable antibiotics like cefalexin, cotrimoxazole, or doxycycline. So clindamycin should be used in for its antitoxin properties. That was the second point, antimicrobial therapy. Third point is optimization of predisposing host factors, addressing the underlying structural breaches. Like for example, treat the toe spaces, treat underlying tinea pedis with topical antifungals, prevents portal of entry. Second is manage edema. For example, in patients uh, who have edema, like in patients with cardiac failure or CKD or venous stasis, chronic venous stasis edema. So dependent venous edema should be managed via regulation and customized compression stocking. This is for venous edema, which is secondary infected. Okay. Then diabetes control should be there. Optimize systemic glycemic control to restore nutrient function. Remember, when the diabetes is not controlled, so sugar will be present, glucose will be present in the blood, but to promote utilization of that glucose by the immune cells of our body, insulin is required. So that's why when diabetes is not controlled properly, so your immune system will not act properly and infections become very much common. So that is the optimization of host factor. Treat the toe space infection, meaning treat the risk factor by which this infection has happened. Okay. Then one important point to remember: management of necrotizing soft tissue infections. It is a surgical emergency. Surgical emergency, managing immediate, aggressive, repeated wide excisional debridgement, skin, fat, fascia, muscle until viable bleeding margins are achieved. Survival depends linearly on time to surgical debridement. Broad spectrum antibiotics initiated without delay, comprehensive coverage, gram positive, gram negative anaerobes. Example, piptazo plus vancomycin, and add potent proteins like clindamycin. Okay, so you start this broad spectrum antibiotic and refer to the surgical department, and debridgement is required. So this is the three triad of management of SSTIs. So mild non-purulent cellulitis, give 5-day course of antibiotics is enough. If the patient shows signs of improvement like stabilization of erythema, otherwise not progressing, and other thing is resolution of systemic symptoms, then you can stop the antibiotic. And in cases of mild purulent SSTI, you can use antivirals as adjuvant, and that to which highly bioavailable like doxycycline, cefalexin, and cotrimoxazole can be used. But pus, if it is there, then you should have a cover for MRSA. So doxycycline and cotrimoxazole have a cover for MRSA, but cefalexin cannot cover MRSA. Okay. For moderate to severe, you should have IV. Then you should transit to oral once the patient is stable and the lesion becomes non-progressive. That's the thing. Now, this one. What should be the enteric regimens? Okay. So drug names, standard dosages, and contraindications. Empiric antibiotic regimens for mild to moderate. Mild to moderate means only mild. Okay, not moderate. Moderate, you should have IV antibiotics. Adult outpatient and oral step-down therapy. So for non-purulent infections, mainly caused by streptococcus, and in some cases, methicillin MSSA, meaning methicillin susceptible Staph aureus. Number 1 drug is cefalexin, and number 2 drug is amoxicillin clavulanic acid. What is the dosage? Standard dose of cefalexin is 500 mg per oral twice daily. Renal adjustment is required only if it falls less than 30, meaning G4 stage you should have adjustment. Okay. So you should give, if it is 15 to 30, twice daily should be given, and if it is less than 15, every 24 hours should be given. Clinical pearls about cefalexin. So it is the first line for cellulitis, remember, because it has excellent bioavailability but lacks MRSA coverage. If there is no pus, there is less probability of having MRSA. Okay, no pus. So excellent bioavailability, cefalexin. Okay. Then, so because of even though cefpodoxime also has this streptococcus property, but because of bioavailability property, this cefalexin is preferred, and it is in the guidelines only. Second is amoxicillin clavulanic acid. In the standard dose of 875 or 125 mg twice daily, it should be used, or 500, 125, 625 mg thrice daily should be used. Renal adjustment only if GF falls less than 30 creatinine clearance. It should be used twice daily, 500 mg amoxicillin if it is between 15 to 30, and if it is less than 15, it is once daily. Clinical pearl about this is for animal and human bites, Pasteurella. Amoxicillin clavulanic acid is the drug of choice for animal and human bite. Remember this point, okay? Because it covers oral anaerobes. But one thing is it causes GI upset. So this is for mild infection. Okay, this empiric antibody is for mild infection. Now for purulent infection, one thing is bacterium DS, nothing but cotrimoxazole. Number one. Number two is doxycycline. Number three is clindamycin. Okay, still it is there. Okay, so you can do cotrimoxazole 1 to 2 double strength tablets per oral twice daily. Standard dosage is ideally 1 to 5 mg per kg per day. Okay, renal adjustment only if less than it falls less than creatinine is less than 30. Less than 15 it is not recommended. Pearl is it covers MRSA. That is very important point. It covers MRSA. In purulent infection, because it covers MRSA, it is recommended. Okay. Pus means MRSA should be covered. So these are the 3 drugs which cover MRSA. Now MRSA, but poor, this streptococcal activity is very poor. Contraindication for this sulfa allergy. Third trimester you can't use this bacterium, and hyperkalemia risk is there, and acute interstitial nephritis. So AKI can occur if you use bacterium DS. That means you should not use this in. You should use carefully this in patients with CKD. Doxycycline. So it will cover MRSA as well as atypicals. For example, like a patient who have exposure to salt and water. So like Vibrio vulnificus. So there doxycycline can be used. That is an atypical bacteria. Okay. Vibrio vulnificus. Okay. Standard dose is 100 mg every 12 hourly. Renal adjustment nothing is required for. So this is very important. Renal adjustment is not required in case of doxycycline. Clinical pulse, it has anti-inflammatory properties also. One important thing is it should be taken along with a full glass of water because it causes esophagitis, heartburn. Okay, very easily. Esophagitis. Contraindications: pregnancy you can't use this. Children less than 8 years you can't use this. So that's about the second antibiotic. So bacterium covers only MRSA. Doxycycline covers MRSA and atypicals. Clindamycin covers MRSA as well as streptococcus. Both it covers. But use for MRSA is declined because of rising resistance. But still it can be used. It is used very much. Okay. Standard dose is 300 to 450 mg per oral thrice daily TID. Renal adjustment is not required. This is one important. So doxycycline clindamycin does not require any renal adjustment. Clinical pulse, you can use it as empiric therapy only if focal resistance low. I use it very much. I don't see resistance in my area especially. I had given to one patient when linezolid, but he did not. It was a purulent infection. But he didn't respond to that, and I replaced that linezolid with clindamycin. Empirical, I'm talking about, because the culture report was like no aerobic bacterial aerobic growth seen. So culture growth was negative. So I used linezolid, but the patient was not improving. Then I replaced linezolid with clindamycin. Patient improved very rapidly. So even though guidelines so it depends upon your area. Okay, if it has a low resistance, then clindamycin is a very much good drug still now. So see your aerial resistance, then you decide. But one thing is it has a very high risk of Clostridial difficile. Okay, so that you should remember. Okay. Now for severe, meaning moderate to severe infection, IV antibiotics should be used. So let us discuss now. One is severe non-purulent, second is severe purulent, third is necrotizing fasciitis, fourth is toxic shock syndrome or type 2. Remember, necrotizing fasciitis has 2 types. One is type 1, which is polymicrobial, and one is type 2, which is streptococcal, mainly fulminant streptococcal. So first let us discuss severe non-purulent or in failed per oral therapy. So moderate to severe, what drugs should be used? So guidelines suggest cefazolin and ceftriaxone once daily, convenient dosing. Okay, so because mainly streptococcus is our target, that's why we are using. So second alternative you can use is clindamycin. Why? Clindamycin covers both MRSA as staphylococcus as well as streptococcus, so you can use this. So target deep streptococcal burden and rapid lymphatic spread. High dose IV beta-lactams provide aggressive coverage. So for moderate to severe non-purulent infection, we can use ceftriaxone or clindamycin. Okay. Severe purulent infection, you should cover MRSA. So that is the main point. That's why you should use antibiotic which covers MRSA. So you should use number one choice is IV vancomycin. Dosage is 10 to 20 mg per kg IV every 12 hours. One important thing is it requires therapeutic drug monitoring. Okay, that one important. Okay, Alternative drug is daptomycin or linezolid. Okay, every 12 hours, 600 mg. So vancomycin or linezolid. One important about linezolid is it is anti-MRSA, one thing, as well as it halts it has antitoxin property also. Linezolid, one thing is anti-MRSA, second is antitoxin property. That's why if you use linezolid, then no need of using clindamycin, because linezolid has both properties. Okay, so why we are using this one? We need to cover MRSA. Linezolid provides excellent deep tissue penetration, suppresses toxin production, both it can cover. But what are the side effects? You should remember there is a risk of thrombocytopenia, okay, and risk of serotonin syndrome if you use this with SSRIs or SNRIs or atypical antidepressants, atypical tricyclic antidepressants. Sorry, if you use it with tricyclic antidepressants, SSRIs or SNRIs, there is a risk of serotonin syndrome. Okay, that you should remember. So be careful while using linezolid in patients, psychiatric patients. Daptomycin, it is deactivated by pulmonary surfactant, cannot use for pneumonia, but excellent for skin infection. But daptomycin is not used very much. Vancomycin and linezolid are used. Okay, so that was about severe purulent infection. Okay, now coming to the necrotizing fasciitis type 1. So type 1, remember, it is polymicrobial. That means you require gram positive, gram negative and anaerobic coverage. So for that, because it is purulent, you require MRSA coverage also. So you give Piptaz 4.5 gram IV TID along with vancomycin IV. Okay, or alternative is meropenem. Again, this will cover all plus vancomycin. This is alternative. So maximum broad spectrum coverage for gram positive, gram negative, including pseudomonas in high risk host, and deep tissue anaerobes is required, pending urgent surgical exploration and deep operative cultures. So suspected, you should start this Piptaz, vancomycin and clindamycin, and you should refer to the surgical department. Necrotizing patient. So toxic shock syndrome or type 2 necrotizing infection. That means in type 2 necrotizing infection, you have this toxin production. So there, now the first drug of choice in toxic shock syndrome is clindamycin, and the dosage is 900 mg IV every 3 hours. The dosage is high. See, actually it is 600 mg IV use, but here it is 900 mg IV, and oral it is 300 mg to 450 mg. Remember this. Or you can so you should use clindamycin along with penicillin G IV. Okay, you can consider IV immunoglobulin as an adjunct for refractory shock. So clindamycin acts upon the 50S ribosomal subunit to immediately shut down the synthesis of superantigens like SPEA and pantone valentine leukocidin toxin, functioning independent of the bacterial growth phase. So that's about the management of mild as well as moderate, severe, purulent as well as non-purulent infection. Okay, let's move on forwards. So this is the last management algorithm for purulent as well as non-purulent SSTI. So patient presents with suspected skin and soft tissue. First, anytime for every case, remember, you should always, for any condition, maybe cardiovascular, respiratory, skin infection, or any disorder of human body, you should always first remove the red flags. You should look for red flags. Evaluate for red flags like necrotizing soft tissue infection if you have clues for that. Toxic shock syndrome if the patient presents with hypotension, fever, okay, organ dysfunction. Patient is not stable, hemodynamic instability is there, then that is a red flag, and immediately you should start IV antibiotics. What should be the empirical antibiotics? Piptazo, vancomycin, clindamycin, because you are covering gram positive, gram negative, anaerobes, pseudomonas, MRSA as well as antitoxin. And if it is necrotizing soft tissue infection, urgent surgical consultation is required for debridement. Okay. Now, if there are no red flags, then what you do, you classify based upon pus present or not present, and then mild, moderate, severe. Two classification. Now, pus present, purulent infection. Now you classify as mild, moderate, severe. For mild, no systemic signs, immunocommitted, incision drainage along with adjuvant oral antibiotics. If the lesion is more than 2 cm, cotrimoxazole you can give, or doxycycline you can give. Okay. For moderate and severe, IV antibiotics should be given. Remember this point. IV antibiotics should be given. After giving IV antibiotics, when the patient's vitals are stable and systemic signs are resolved and the arrhythmia is not progressing, then you should uh, step down to oral therapy. Highly bioavailable drugs like doxycycline, clindamycin, cotrimoxazole in case of purulent infection, and cephalexin and amoxicillin in case of non-purulent infection. So that is for moderate and severe. So IND, empiric oral cortisone modulation, just remember that one. Okay, IV therapy. Then for non-purulent, one thing to remember is, even though guidelines say this one, the drug which you use and the patient is responding IV, the same drug should be used orally also. So that is a traditional way of treatment which I am discussing now. So if you have used linezolid IV for some purulent infection and you are stepping down now, then better to use oral linezolid only. Okay, even though the guidelines say uh, use highly bioavailable drugs like cephalexin, cotrimoxazole, doxycycline. Now that depends upon the physician who is treating the patient. For non-purulent infection, again mild, use cephalexin or amoxicillin for only 5 days. I said no. Okay, and for moderate to severe infection, again you should use IV drugs. So ceftriaxone is the drug of choice IV here, and in purulent infection, vancomycin is the drug of choice. Alternative is linezolid. Here ceftriaxone is the drug of choice. Alternative is clindamycin. Okay, moderate to severe. That's all. And one important point is that is for moderate. For severe infection, better to have a broad spectrum. So always remember. So there we have studied like in severe infection, use ceftriaxone, and if you have purulent, then use linezolid. No, in severe infections, whether it is purulent or non-purulent, in purulent infection, if it is severe, then use IV coverage of linezolid or vancomycin. But in case of severe infection, one important point to remember here is, okay, moderate infection you use ceftriaxone in non-purulent. But if it is severe, if it is severe, non-purulent SSTI, if it is severe, then you should have MRSA coverage along with broad empirical coverage. Like IV vancomycin and piptas you should use, okay, if it is very much severe. That I need to share, and that we have discussed in initial classification also. Unless the non-purulent SSTI is severe, MRSA coverage is not required. If the SSTI is severe, non-purulent SSTI is severe, then MRSA coverage is required. That we need to remember. Okay, so that's the end of this topic. Thank you for your listening, and do share, comment, like, and subscribe. Thank you.